Hello, welcome back to Lecture 1 for Module 4, Community Health Advocacy and Social Movements. We were discussing clinical monitoring programs in our last lecture, and we ended with the example of the Diabetes Care and Outcomes Audit with the Indian Health Service, which is a clinical diabetes surveillance program. Now we'll move on to prescription monitoring programs, PMP. And there are many programs like this nationwide. Washington State Department of Health in Olympia has a PMP. It's also called Prescription Review. These programs were made when it was identified that prescription of opioids and other pain medications are being overprescribed by doctors. And largely that might be the responsibility of the provider, but often patients put pressure for that, and there's different reasons why it's happening, but it is happening, and it's leading to a lot of addiction and sometimes even death. So we have the prescription drug misuse, and the idea of the program is to stop that by collecting and dispensing records for Schedule 2, 3, 4, and 5 drugs. This makes information, the PMP makes information available to medical providers and pharmacists as a patient care tool. It took effect August 27th in 2011. The program started data collection the same year from all dispensers in Washington State in October. And if you want more information about this, basically it's just another example for our purposes of a clinical monitoring program. This is the Washington State Health Department website. And it shows how providers can use this program, and all the sort of technical details of how providers take part in this, and dispensers, and what the laws and rules are, and different resources that that people who are administering a PMP program or taking part can learn from. National level drug laws and the National Association of State-Controlled Substance Authorities, PDMP training, and SAMHSA, which is a big organization that's very proactive in advocacy and giving out grants and facilitating programs that deal with substance abuse. So there's a lot of resources on this website for PMP dispenser programs and dispensers of Schedule 2 through 5 drugs. So it's a good website. Take a look if you have time. So assessment. So assessment is complicated in community health, with so many variables and so many people involved. But you could break it down into 2 phases: the initial investigation and the end, the pre and post data collection. And in the pre-data collection, we're talking about the community needs assessment that we'll be learning about in week 10 of your other class, CHP 300, which is finding out what is needed and what is desired by the community in the way of health programs. And then service gaps could be among community needs, but generally those are identified by service providers. An example being if there's many people showing up in the clinic with symptoms of diabetes and high blood sugar, maybe we don't have good prevention programs. Maybe we don't have pre-diabetes screening. Maybe we don't have any adult exercise free programs in the community, um, or nutrition education. So that might be looking at what kind of outbreaks or outcomes we're having in with as far as service providers go. We might be able to identify service gaps. And often these two will not be the same thing. There may be many people in the community uh, with a diagnosis of diabetes, but they feel that that the services that they need more are um, cancer screenings because their elder relatives have cancer and they want to know if they're at risk. So that might be different. Community needs and service gaps might be the same thing. In any event, these are both very important parts of pre-data and the assessment as a whole when you're talking about community health. So baseline data is the initial data that you'll be collecting once you have your research question, you're starting your program. It's sort of an understanding of what is the current utilization of the services that you're looking at, or what is the current outcome before you introduce your program. And then evaluation is using that baseline data to see the change in the population who have used your program or who have gone through it. So this is really important for understanding the change in outcomes and in knowledge or in behavior or whatever you're hoping to assess. Quality assurance, well, evaluation. So we'll have a whole class on evaluation. So this is a humongous topic. But what I can say in a nutshell is this is one of the most important parts of community health programming because we want evidence-based programming. So these evaluations provide that evidence. Yes, this worked. No, it didn't work, or whatever you're hoping to see. And it prevents a lot of expenditure that might be a waste. If you wanted to scale up your program when you sort of first thought of it and you try it out and it doesn't work, it saves you the whole hassle and expenditure of scaling that up. So to every other health clinic in the city of Tacoma. So that's a really important for building an evidence base on what kind of programs work or don't work. And at the end of the day, utilizing that information to make your program better or help someone else make theirs better. And quality assurance, so HEDIS is an example of quality effectiveness in clinical care. And so you can look that up. We have it on a previous lecture link. Community feedback is one of the most important in my mind for assessment because you find out things you never might have known about your program. You might find out that you have great outcomes and great participation and good reviews of the program, but you see out of your 200 people that only 10 were women. And it's like, what? What happened? So then you get the feedback from the community and you find out women didn't like to exercise in front of men, or they didn't feel safe in the waiting lounge with all the strange men that they didn't know, or whatever it is. You find out some of the culture gaps between yourself and the community that you're working with, or you find out some of the assumptions or things that were forgotten when you get this community feedback. So it's really important for the overall process of community health program assessment. So let's move on to chapter 4. Just quick review over this. This was a very effective screening, the sickle cell anemia screening programs undertaken by the party due to the neglect of the condition by mainstream medical establishment, and for this reason dubbed as genocide. And I thought maybe this was a little strong of a word, but after reading into the chapter more, it was clear that the discrimination shown to the two nurses, one was not admitted to nursing school and one was let go of her job for testing positive for the trait or for the condition. And just the way patients were neglected, no one was doing research on the disease. And that just showed in the context of the pain and how painful it was, and accounts that I've heard from people whose family members have suffered through sickle cell anemia, just how like the excruciating pain and why this term came up. So for this reason, it was a highly politicized subject because of just how severe the nature of the condition can be and how much discrimination and neglect and just causing invisibility of the patients experiencing this. So the brilliant sort of aspects of this were employing a simple, portable, and cheap test that they could use for the public campaigns and events in parks and schools at Walla Walla. They also had the electrophoresis test to identify the presence of hemoglobin S, which is a gel electrophoresis. And I'll show you, this was actually a page that I was looking at. So it's more complicated than that. And it's on medscape.com, so you can register for free and look through this. It's actually a really great description in detail of what the electrophoresis test shows. And it was a highly successful education campaign and screening program that got attention from the government, big donors. So just to summarize the disease, it's a heritable condition that causes red blood cells to take a sickle shape rather than a round shape. And it's an adaptive and favorable trait in areas where malaria is endemic. People can be carriers with little or no symptoms, or test positive. Causes bouts of severe pain and weakness due to anemia, was a source of discrimination by employers for this reason, such as the nurses, and did not have a known cure at that time. But since then, it's been discovered that bone marrow transplant is an effective treatment. So Dr. Kleinman, the anthropologist, talks about the difference between illness, sickness, and disease, which I thought was thoughtful. And illness is basically how a sick person and the community perceive, live with, and respond to symptoms and disability. Sickness is the narrow technical definition, understanding of bodily infirmity, most often held by medical professionals. And disease is understanding of a disorder, of a disorder in relation to macro-social, so the economic, political, institutional forces. So taking it to a social health perspective, he kind of breaks this down, which I thought was interesting. You have your prompt, which is a little bit different from this, so I'll skip by this quickly. It's on Canvas now. And your next project update is coming next module, module 5. So don't worry about starting this, but your discussion describes how we can start brainstorming for this. So check out Canvas. You'll find your discussion on chapter 4 and prevention and screening programs, and have a great rest of your week. See you next time.